With that background, let me introduce our first speaker, Dr. Anna Locke, probably well known to almost all of you. She is professor of medicine and director of clinical hepatology at the University of Michigan School of Medicine. She is the former president of the American Association for the Study of Liver Diseases, the AASLD. She's a member of the National Academy of Medicine and has been a principal investigator on many of our NIDDK clinical networks, including the HALT-C trial. She was the chair and the lead principal investigator on the HBRN. Dr. Locke will summarize the major results from the HBRN cohort study. Dr. Locke.
Well, thank you very much, Jay, for the introduction. And thank you also, Dr. Watt, for the opportunity to present our results. So I hope that you can see my screen, and I will. Okay. As Dr. Hufnagel mentioned, I'll be presenting the major clinical outcomes. These are my financial disclosures. So the Hepatitis B Research Network consists of 13 consortium, 21 adult and 7 pediatric sites. Most of them in the United States, but we also included one center in Toronto, Canada. We did 2 observation studies with similar protocols in adults and children, and 3 clinical trials, one in immune-tolerant e-antigen-positive children and adults, and one in immune-active adults. And there were 30 ancillary studies. So I will focus on the adult cohort study. And the key criteria for entry would be someone who's hepatitis B surface antigen with no history of decompensation, liver cancer, or liver transplantation. And at the time of enrollment, they would not be receiving antiviral therapy unless they're co-infected with Delta infection or they were pregnant. After the initial enrollment and data collection, they were seen again at week 12 and then every 24 weeks thereafter. At each visit, we ask them questions, we have patients complete surveys, and we provide standard of care because this was an observational study. And the standard of care also includes liver cancer surveillance as well as antiviral therapy if indicated. All the outcomes were predefined and adjudicated by a committee. So this is the location of all these clinical centers of HBRN. I would focus on the clinical outcomes, and a major clinical outcome, as you would expect, would include decompensation, liver cancer, liver transplant, or hepatitis B related death. Majority of the patients did not have cirrhosis at enrollment, so we were also interested in knowing whether any patient developed incident cirrhosis during the course of follow-up. This will be determined either by histology or, in the absence of histology, by imaging criteria and low platelet count. Chronic hepatitis B is characterized by ALT flares. So we were also interested in looking at flares, which is defined as ALT more than 10 times upper limit of normal, with 30 being the criteria for cutoff for men and 20 for women. As I've mentioned, these patients were not receiving antiviral treatment at enrollment, and we wanted to know how often patients are started on treatment per standard of care and looking at e-antigen loss and S-antigen loss as well. Of the 2,000 or so participants enrolled, we selected the following for the outcome analysis. These were all adults with chronic hepatitis B. You will hear later on that some of the patients come in with acute hepatitis B. So this analysis focused on those with chronic hepatitis B, no HIV, hepatitis C, or Delta co-infection, not receiving antiviral treatment at enrollment, and not started on treatment during the first 24 weeks. They were not pregnant at enrollment. Because we're interested in long-term outcomes, they need to have at least one follow-up visit more than 24 weeks after enrollment. So in total, we had about 1,400 participants, median age of 41, roughly half of them were women. Despite the fact that this is a North American study, majority of these patients were Asians, but 13% were Blacks and 10% white. Most of these patients were e-antigen negative, only a quarter of them were e-antigen positive at enrollment, and median HBV DNA was low because these patients are not on antiviral treatment, because they were predominantly Asians, So genotypes B and C predominate, but we did have 17% genotype A and 7% genotype D, and a very small proportion of genotype E. The requirement for not on antiviral therapy means that very few patients had cirrhosis at enrollment. Well, what about the HBV phenotypes? Very few immune tolerant because of the somewhat older age of these participants, only 4%, 17% e-antigen positive immune active, 18% e-antigen negative immune active, 24% inactive carriers, 37% indeterminate. This is not necessarily representative of chronic hepatitis B patients we see in clinical practice, but representative of patients not receiving antiviral treatment at the time of enrollment. So in general, less cirrhosis, less active disease. So we had roughly 5 to 6 years of median follow-up with a total of more than 6,000 person year of follow-up. And you can see that very few patients had major clinical outcomes. Only 26 of the 1,400 participants had outcomes, and that included instant cirrhosis. Most of these patients were not on antiviral therapy. Only 5 of them had started antiviral therapy at the time of outcome. Some of them were initially e-antigen positive, but had lost e-antigen by the time of outcome. But none of the patients had outcome who lost surface antigen had outcome. As one would expect, majority of the outcomes occur in patients with cirrhosis. So of the small number, 21 baseline cirrhosis, 4 major outcomes occurred. 3 were liver cancer and 1 died. Of the roughly 1,400 with no baseline cirrhosis, there were only 4 of them with major outcomes. 2 liver cancer, 2 decompensation, though 18 of them did meet criteria for instant cirrhosis. So in total, there were 8 participants with either decompensation or liver cancer. And as is the case with chronic hepatitis B, most of these outcomes occur in men, a little older. Surprisingly, actually more of them occur in Caucasians, even though Caucasians only accounted for roughly 10% of the study population. So this actually helps you sort of see this more clearly. Total 1,400, baseline cirrhosis 21, and most of the outcomes occur in those 21 patients. Of this large cohort without baseline cirrhosis, there were very few outcomes, only 2 cancer, 1 decompensation, 19 had incident cirrhosis, 1 actually had decompensation at that time. So overall, there were very few HBV-related deaths, 1, 2, and 3 in total. This shows time to event of the major outcomes. Again, most of this occurred in a group with baseline cirrhosis, 16% by year 4. In those with no baseline cirrhosis, by year 4, only 0.2%, and even by year 7, less than 1% had major outcome. Now, if we include instant cirrhosis, then the event rate was a little higher, 2% at year 7. We were also interested in ALT flare, which can sometimes be potentially serious. And indeed, 83 patients had ALT flare, and cumulative percentage at year 7 was 8%, somewhat lower than one would expect. The associated factors, so the people who have flares tend to be younger, e-antigen positive, more likely to have cirrhosis, higher DNA, higher quantitative surface antigen, and higher ALT, and lower platelet. Well, why did we see so few outcomes? Well, that's because even though these patients were not on treatment at entry, many of them during the course of follow-up did start treatment. Nearly 300 of them started treatment per standard of care. And now, additional 111 that were enrolled into clinical trials, although they were censored at the time of entry. So in total, roughly 400 of them did start treatment along the way. And cumulative percentage by year 7 of starting treatment per standard of care was nearly 30%. As you would expect, e-antigen positive, cirrhosis, higher DNA, higher ALT were associated with starting treatment, where Asian patients were more likely to start treatment, largely because they were more often e-antigen positive with higher DNA. Well, what about e-antigen loss? We did observe roughly a third of the e-antigen positive patients lost e-antigen. So by year 7, in fact, almost half of them. Interestingly, most of the e-antigen loss actually occurs spontaneously and not as a result of treatment. And associated factors included older age, genotype A, lower DNA, and lower quantitative surface antigen. Loss of surface antigen is something that we had always hoped for, and indeed we do observe that. 90 of the 1,300 patients who had follow-up testing lost surface antigen. Again, majority of them spontaneously and not through antiviral treatment. And the cumulative percentage by year 7 was 12%. Associated factors include older age, men, non-Asians, e-antigen negative, lower DNA, and lower quantitative surface antigen together with normal ALT. So essentially, they were older inactive carriers and non-Asians that were more likely to lose surface antigen. So overall, in this part of the analysis, we found a low instance of clinical outcomes in a contemporary cohort of chronic hepatitis B patients not receiving antiviral treatment. This actually should be 18% per year over 4 years. So most, not receiving antiviral treatment. So it's actually less than 1%. So most outcomes occur in patients with cirrhosis, and no outcome occur after surface antigen loss. Well, why do we have favorable outcomes? I think it's because of the low percentage of cirrhosis or active disease, and a high percentage starting antiviral therapy during follow-up. We conclude that early diagnosis, linkage to care, close monitoring, and treatment initiation when indicated can prevent adverse outcomes, and treatment upon diagnosis may not be necessary for all patients. So that's really highlighting the importance of treatment overall. Now, one of the things that we were interested, because HBRN included a diverse racial ethnic group, and we know that chronic hepatitis B disproportionately affects persons of Asian or African descent, and Asian Americans and African Americans have higher incidence and early onset of HCC than white persons. We wonder whether this is due to racial differences or differences in duration of infection, HBV genotypes, or social determinants of health or access to treatment. So we analyzed whether treatment initiation and outcomes differ between Black, Asian, and white participants. And for this, we included adults with data on self-declared race, chronic hepatitis B with no HIV, hepatitis C, or Delta co-infection, with follow-up for at least 24 weeks. And we defined treatment initiation, including those who started treatment per standard of care, as well as receiving treatment through HBRN trials. We also look at concordance between starting treatment and treatment eligibility, because currently we do not recommend treating every patient with chronic hepatitis B. And we used the 2016 AASLD guidance document. So we look at cirrhosis. Everyone with cirrhosis, regardless of ALT or HBV DNA, we said treatment will be indicated. Among patients without cirrhosis, it would be e-antigen positive, DNA more than 20,000, and ALT more than 2 times upper limit of normal. For e-antigen negative patients, the DNA cutoff will be more than 2,000. And we look at concordance of treatment initiation and treatment eligibility. So that would be older patients with cirrhosis, and for patients without cirrhosis, those who meet guidance criteria on 2 consecutive occasions, as well as when they meet criteria on the first time. So for this analysis, we had done 1,500 participants, not 12% Blacks, 75% Asians, 10% white. We found differences between these 3 major racial groups. Black participants had lower education level, income, and proportion being employed. And Black and Asian participants were more likely to be foreign-born and uninsured or had public insurance. The Black participants were more likely to be e-antigen negative, and among those who were e-antigen negative, to have lower DNA than the Asian participants. So I'm showing you a few social criteria between the African Americans, the Asian Americans, and the whites. You can see that for the education level, those who had only high school or lower education level were more common in Blacks and Asians than in the whites. And Blacks had lower income. Less of them were being fully employed. Less Blacks and Asians had private insurance. And of course, the Blacks and the Asians were less often born in North America. So there are definite social differences. So what happens to the outcome? Well, as far as treatment is concerned, overall, roughly a third of them started treatment during the course of follow-up. And if you look at the cohort as a whole, the Blacks were less likely to start on treatment. The Asians were most likely to start on treatment. But that's because of differences in meeting criteria for AASLD guidelines to start treatment. The Blacks being more likely negative, low DNA, only 14% would meet those treatment criteria compared to 22% in Asians and 27% in white. And if you look at people who met criteria for starting treatment, there was actually no difference across the three racial groups. Not surprisingly, those who got started on treatment tend to have higher ALT, higher DNA, more likely to have cirrhosis, and more often were men. And neither race nor socioeconomic factors were significantly associated with treatment initiation once we adjust for these viral or disease factors. So when we look at everyone, regardless of whether they meet treatment criteria, the Black participants had lower rates of treatment initiation. But once we focus our attention to those who meet criteria, we found no difference whether we start counting when they met criteria on consecutive occasion or on the first time. There was no difference across the racial groups. And when we did multivariate analysis, the factors associated with treatment initiation were higher ALT, higher DNA, presence of cirrhosis, and older age. But there was no difference for education, income, type of insurance, or how long they have lived in North America. So we conclude that in this North American cohort of racially diverse adults with chronic hepatitis B, treatment initiation were higher in the Asians and lower in the Blacks, but that really is related to differences in disease characteristics, viral characteristics, and differences in proportion meeting treatment criteria. And among those who had a treatment indication, treatment rates did not differ by race, despite marked differences in education, income, and type of health insurance. And race was not an independent predictor of time to treatment initiation when adjusted for disease and racial factors. And clinical outcomes were very rare, as I've shown you earlier, regardless of the race. So I want to thank NIDDK for sponsoring the study, and these are the participating sites, and these are our grant numbers. Thank you for your attention.
Well, that was a terrific presentation of a lot of data, maybe overwhelming. What proportion of patients in the HBRN were foreign-born?
Well, it's close to 80%, so 75, 80% being foreign-born. And this is because many of these patients actually acquired hepatitis B, were infected with hepatitis B before they were immigrated.
I see. And were there differences between the foreign-born and American-born subjects in time to treatment if they qualified for?
Among those who met criteria, there was no difference in terms of how long they have lived in this country.
Right. So one of our questions is, was treatment paid for by the study or by the patient's insurance out of pocket?
Well, for the patients who were enrolled into one of the HBRN trials, the study provided a treatment. But there were also other patients who met some treatment criteria and were started on treatment per standard of care, and those were being paid for by insurance. But we actually also look at whether people were on commercial insurance versus Medicare, Medicaid, and whether that played a role in treatment initiation, and that was not associated.
Right. So basically, these data support the AASLD guidelines i.e., if you have cirrhosis, you should be treated regardless. And was that found in the outcome analysis that those with outcomes were not treated?
Yeah, unfortunately, a couple of these patients who had outcome, they were started on treatment after the outcome occurred. Because this is an observational study, so sometimes we don't understand why the patients were not started on treatment, whether it's because the patients refused to be on treatment, whether the provider did not recommend a treatment, or whether there were other reasons.
Right.
Bear in mind that even though we think that all the HBRN investigators are experts in hepatitis B, the patients are being managed per standard of care. So sometimes they're being managed by our colleagues and not necessarily the HBRN investigators. And some of the patients choose to sort of say, I don't have symptoms now. I don't want to be on lifelong treatment. Right.
Now, I guess we have the other side of that is that patients who don't have cirrhosis, who don't fit the ASLD criteria, seem to do fine. And so that supports that you don't need to treat everybody, right?
Yeah, I think it's one important message, because I know that is very hotly debated now. Upon diagnosis, put everyone on treatment, and then we don't need to keep monitoring them. Right. Well, first of all, even if you put everyone on treatment, you still need to monitor them, because the most dangerous thing is some people put on treatment and then abruptly discontinue treatment and are not being monitored. That can also be risky. And what we show is, if we follow patients as the disease progresses, as the virus becomes more active, you catch them, you put them on treatment, you can prevent adverse outcomes.
Yes. So we have a question about the people who don't qualify. When will we have a therapy that clears surface antigen, maybe a vaccine or something?
Well, we all know that there's a lot of research into curative therapy, new antivirals, immunotherapy. There are a number of them that show promise, but they're not ready yet for prime time. And I certainly hope that in the next few years, we'll have some of these being ready and approved.
And the final question is, what methods were used to diagnose cirrhosis? Were these actually being done during the trial, during the cohort study?
Well, in HBRN, as everyone knows, we don't do liver biopsies as often as we used to. For patients enrolled into the immune active trial that Nora will talk about later on, all the patients need to have a liver biopsy for entry. During the course of clinical standard of care, only a small proportion of patients had liver biopsies. So the diagnosis of cirrhosis were either based on histology or imaging, ultrasound, CT scan, looking for nodular liver, evidence of portal hypertension to get a low platelet count.
So it's not completely reliable, but neither is liver biopsy, huh?
Yeah, and unfortunately, at the time when we started the study back in 2009, 2010, FibroScan was not widely available in the US. So Very few of our patients have FibroScan testing at that time.
That would have been helpful. So we need to move on. Thank you,